Happy Friday, everyone. This is Ray Pedden from the Center for Care Innovations. Welcome to CCI's Raven e-learning series. The Raven e-learning series has been developed to highlight technology solutions that address priority areas that have been identified by the safety net provider community. Raven has been developed as a CCI learning laboratory for the safety net. To join Raven and to take advantage of all the platform has to offer, please visit raven.careinnovations.org. The series is designed to be a learning opportunity, and we encourage attendees to engage with faculty during this session. You can see future topics in the series at raven.careinnovations.org/e-learning. Today's session is focused on risk stratification and population health. We will be discussing how do I think about quantifying the risk embedded in my patient population? What sources of data are there that can be used for risk stratification? How do I turn risk stratification into actionable information? We have a distinguished faculty for today's session that includes Dr. Anshu Abhat, who's the Director of Digital Patient Engagement, Department of Health Services, Los Angeles County, also Assistant Professor in Internal Medicine at UCLA. Debra Duran, who's the Chief Nursing Officer, Ambulatory Care Network, LADHS. Ann Moreno, who's the Ambulatory Care Network Nurse Manager, Orchid Nurse Informatics at Department of LADHS. We also have Mike Aratow, a physician from San Mateo County Medical Center, who is also an emergency doc and a Chief Medical Informatics Officer in San Mateo, along with Bradley Jacobson, who's the Population Health Analytics Manager for San Mateo County Medical Center. Finally, Dr. Danielle Oryn, who is the Chief Medical Officer, Chief Medical Informatics Officer for the Redwood Community Health Coalition. Please welcome our esteemed faculty. And at this time, I will turn it over to Debra Duran from LADHS. Debra.
Hi, good afternoon, everybody. It's a pleasure to be here. Okay, that's what I was going to ask for my slides. Are they coming up?
Yep. I forgot. I'll frame the issue just a second here. Basically, what we're looking at here is the role and how to use risk stratification and data associated with your patient population in the safety net. And the first case up is with Los Angeles DHS, Debra Duran.
Debra Duran.
Duran. Oh,
that's okay.
I'm sorry.
That's fine. It's fine. Debra Duran. Hi, everybody. Good afternoon. I'm here to share our journey as we embarked with our Cerner partners. We're a Cerner shop, so we consulted with our Cerner partners to find ways to identify who our impaneled patients are, and then also to set up some registries to help us with population health in that regard with registries. And what I'm going to focus on mostly is the care management component. We also, you can go to the next one. We also decided that we needed a method to, once we knew who our impaneled patients were and we had them into the registries, we also wanted to know who are the most complex. Who are the, how can we stratify those patients so that we know who are the most complex patients and then focus our efforts for complex care management on those patients. So we embarked on a project. We will talk about some win-win strategies. We'll talk about how we coordinate the care of those patients and how we effectively implemented this enterprise-wide care management system. Next slide, please. That's just a picture of LA County, nice and sunny as it is today. Okay, so who we are. We're the second largest public health system in the nation. We have approximately 360,000 empaneled lives. We have over 200 patient-centered medical home teams. And you see the map there, the geography is quite large. It takes, some of our clinics are up in Lancaster and Palmdale in the high desert. It takes about an hour and 15 minutes to get there from downtown LA with no traffic. It's quite a long distance And so we're spread out all over the place. We have 27 facilities throughout that entire county and approximately 94 RN care managers, registered nurses.
Before we go further, can everybody mute their microphone unless you're the speaker, please?
These are just some photos of some of our sites and our mission, our DHS mission. This is a visual representation of how we used our Cerner Millennium, our medical record, electronic medical record, as the foundation, and then we built upon that with some of the other Cerner products like Healthy Intent and Healthy Care, which we refer to as ELM Care Management. And we wanted to do that to make sure that they were integrated solutions and that it was all of our care management activities could be captured in the electronic medical record. So what is ELM Care Management? It's an electronic health record solution that equips our registered nurse care managers to provide a higher level of complex care management to high-need individuals. Our business drivers are aligned with the quadruple aim. We want to, of course, improve quality, improve satisfaction, productivity, and contain costs. So one of the first decisions we had to make was, now that we have our impaneled population, we know who our patients are that are impaneled to us, how do we identify the high-risk patients? So we decided that we were going to use 5 algorithms, and each algorithm is set with criteria that allows the system to pull information from our medical record, our EMR, and from the registries, and it uses claims data, and it identifies those patients that fit the criteria of each of these algorithms. Once it identifies those patients, then it puts them into what we call a potential case list that goes directly to the registered nurse care manager, and then she comes in the morning, she or he comes to work in the morning and can see a dashboard of all of the cases that are assigned to him or her. Prior to that, I should just mention that prior to embarking on this system, the nurses would only find cases, like case finding activities required them to pull reports. So they would pull a report like of the last ER discharges or hospital discharges from the last couple of days. So it was a pull, and it was a report of all patients instead of just high-risk patients. And now what it is, it's a push. They come to work and the patients are.
Debbie?
Okay, sorry.
There you go.
So we can continue?
Yes, please.
Okay, next slide. Here we go. So this is what the care manager or care manager supervisor sees when they come to work in the morning. As you can tell, it's a very colorful wheel, and it tells me, if I'm the care manager, how many patients I have that are new, how many are pending enrollment, how many are enrolled, active, and pending closure, and then it gives us a total. This was a snapshot taken a few months ago for the entire enterprise, the entire DHS. So it's approximately 17,000 total cases at that time, with approximately 6,000 active care plans when this snapshot was taken. So we want to make sure that we can track our outcomes, and we want to know that this is a service that is helping our patients. So we decided, next slide please, to monitor the transitions of care. So whenever, another feature of this solution is that the care managers are notified whenever one of their patients hits the ER or the hospital. So if the patient is assigned to me and I'm the care manager and the patient went to the ER last night, I'm going to find out first thing in the morning when I come to work. what we've asked the care managers to do, we put it in our policy and procedures to call every patient that's discharged, every one of their complex patients that are assigned to them within 72 hours. Our target is 80%, that 80% of those patients will receive a phone call within that time frame. As you can see from this graph, we're not yet at our 80%, but it's a nice trajectory in the right direction. So a year ago in March, we were at 23%. Right now, we're anywhere between 48 and 49%. So we have a nice upward trajectory. In addition to that, our Cerner colleagues helped us by doing a study. So because we didn't actually conduct the research study, they did a statistical analysis, and they found that if you compare a group of patients that are very, very similar, and the only difference between the two groups is the care management intervention, and particularly that they are engaged in care management. So not just the patients that the care manager is starting to reach out to, but actually those patients that are engaged in a care plan. There were improved outcomes for those patients in terms of utilization. So the care management intervention was associated with decreased inpatient utilization of 30 inpatient visits per 1,000, a decreased observation utilization of 5 OB visits per 1,000, decreased emergency utilization 30 visits per 1,000, and increased outpatient utilization, which is what we want. We want them to go to the right venue for outpatient services. Next slide, please. Can you go to the prior one? The other thing we did, obviously, as I mentioned, the triple, quadruple aim, we want to make sure that staff are satisfied. We did a survey 2 months after implementation, and then we repeated it in June, so January and then June. And you'll see on the next couple of slides that there was a significant improvement in the way that the care managers responded to the questions. So how would you rate the ease or difficulty of using ELM Care Management? This one is, how do you incorporate ELM Care Management into your current work? And then on the next slide, ELM Care Management helps me keep track of my patient's progress and overall satisfaction. So it was lower in January. All of them were lower in January, and then much more improved in June. So you might ask, what happened? Well, what happened is we found that right along with our lessons learned is that the registered nurse care managers needed some more support. If we could go back and do this all over again, what we would do is, instead of doing a test of change at 2 sites and then 2 weeks later implementing at all the other 20 plus sites, that was a bit too much, and the support for the end users was spread very thin. So the nurses really needed a lot more hand-holding, a lot more support that we couldn't give them because of the way that we implemented. So if we could do it over again, we would do it in a more phased approach. The other thing was that there was a knowledge deficit. So not all of our care managers, we found out, had received formal care management training. Some of them had, but not all of them. So there were some that were struggling with some of the decisions that they had to make when they were taking care of their complex patients. And so we addressed that through a training. The other thing, the other lessons is the policies and procedures. We were developing them as we were going instead of having them ready prior to implementation. And a big issue also was that the providers were not very engaged in the beginning of the implementation. We had to do a whole plan to get the providers and other team members more engaged because they weren't clear as to what their role was. As a provider, what's changed now that we have this ELM Care Management solution? And there were quite a few changes. We needed them to participate more in case conferences. We needed them to have huddles with the care managers. We needed them to decide together whether this case was ready to be closed, or should we keep it open, or should we refer it to somebody else. And the providers at the launch, during the first go live, were not that prepared because we hadn't engaged them at the level that we should have. So when you see those survey results, they started off not so great, and then in June they were much better because we had done skill sharpeners at all of the facilities for the nurses. We implemented a very comprehensive care management training, and then we also did presentations for the providers and asked their medical directors, their medical leads to help us, get them more engaged. The wins were the clinical training. So now we have curriculum for any new care managers that may be onboarded. It's available and ready for them. We have the refresher skill sharpener sessions that we will continue to implement quarterly. We have all of our documents and job aids and hot sheets on our care management SharePoint. We have our policies and procedures also on the SharePoint. They've been developed, and we are engaging the care managers to make revisions as needed. And of course, the leadership support and engagement is very important and was very helpful. The professional collaboration was an actually unexpected win because we had scheduled, as part of the project implementation, we scheduled what we called touchpoint calls. And those were intended for the end users to identify any technical issues, any kinks in the algorithms, what's working and not working as part of the go live. And what we found is that was really a great forum for all of the care managers who, like I mentioned, may be very separated by large distances and maybe didn't know each other, but they could learn from each other. So they would bring up a case on the call and say, I'm having this problem with this patient. And then another care manager would chime in and said, oh, I had that problem, and what I did was X, Y, and Z. And so instead of those calls ending after 2 or 3 weeks, which we thought was going to happen, we decided to keep them by popular demand available, and they still are in progress today. Ann Moreno, who's on the call, leads the calls, and she can attest to the fact that they share really good stories about their patients. They talk about patients that were homeless with diabetes in the ER and that now are housed. They're in recuperative care, they're getting their wound care, their diabetes is being managed. A lot of success stories, and also opportunities for them to learn from one another of what's not working and what can work. So that was a very good unexpected win. The patient story was the one I just said about the diabetes patient with the wound that was placed in recuperative care. Prior to ELM Care Management was very against going to any venue for assistance. And because of the care manager's engagement and all of the motivational interviewing that she learned how to do in the classes, it just all came together, and the patient agreed to go to recuperative care and was doing very well. So next steps are to ensure that we have complete institutionalization of our ELM Care Management, that the docs continue to stay engaged, that we monitor quality and make improvements and adjustments as we go. But also, you'll see at the end, health homes. That's our next step. That's our next major project. We're working on new algorithms that will focus on identifying the health homes patients. And we're going to obviously modify our policies to make sure that we are in compliance with all of the required for health homes. And if you have any questions about that, I'm happy to take them, but I think I've used up about 15 minutes of your time, so I will leave you with that.
Thank you very much, Debra. And again, if people have questions, please submit them over the chat channel, and we'll get them either during the presentation or collect those for the end. I'd like to introduce now the team from San Mateo, specifically. I'd like to introduce Brad Jacobson. He is the Population Health Analytics Manager at San Mateo Medical Center, and with that, I'll turn it over to Brad.
Hi, everybody. Good afternoon, and Ray, thank you for hosting this presentation. So I just want to talk about some of the work we've done in terms of data and risk stratification at the San Mateo Medical Center. Just give an overview of risk and how to apply for translated into population health activities, and then give some examples. So first of all, obviously what's crucial to any risk management or stratification project is data. And in terms of how we think about it here, it's kind of three big components. There's health IT, and this is obviously the technology and the ability to extract data from our electronic health records. That's sort of their area. And then there's leadership, which is very important. So that includes governance, prioritization, and I'd say prioritization is the most challenging and most important because everybody's tech resources, there's more demand than there is supply. So we have to be very strategic in how we prioritize those resources. Then having the capability to analyze data and also be able to push it out to the clinical staff. So that leads to the clinical staff. So in terms of their role in a risk strategy is just being able to understand the data, help with the validation, make sure that what's coming out of the EHR and going in is really in line with their understanding of their patients. And then finally, and I think most importantly, is to be able to apply it so we result in better decisions and better outcomes and, making sure we're meeting the quadruple aim. So just a very basic definition of risk. So risk is the highest level is loss as a function of loss times probability. So what is the loss of something occurring and what is the chance that that is actually going to happen? So again, big picture, there's two types of risk. There's financial risk, and under that, they're very similar, but there's pricing risk, which is what and making sure that you're setting the right price for a population, and then there's underwriting risk, like what are the events that are happening within the population that you're responsible for. So again, that's on the financial side. On the healthcare side, which is what most of my experience in the work done at the medical center is more on event risk. And, speaking to providers and clinics, it's really about ED visits, preventing deaths, that sort of thing. But again, they're all sort of intertwined and related, and so clarity is very important in that area. So moving on, so risk stratification is just basically taking risk of a person and then try to categorize and put them into groups. Typically, you'll see three in terms of low, medium, and high, either for financial risk or for event risk. And there's just a lot of ways to define groups. Classically, it's been age and gender, but as we become more sophisticated, our data access improves. This can extend to geography, where somebody lives, health behaviors, diet and exercise, tobacco use, past utilization, medical, and family history. So depending on your model, all of those can be used to define a category, a risk category. And then from that, there's basically three uses. In terms of, there's program planning and management, there's provider reimbursement, and there's health plan underwriting. The other point I want to talk about risk and risk stratification is that it's up to each organization to define how they want to use risk and for what reason. I mean, there's a range. It can go from simple to very sophisticated, to do it yourself if you have a talented group of analysts, or you can go commercial in terms of the model of what you want to bring in. So you have basically infinite options. It's just being clear on what you're going to do with risk. Go to the next slide. Okay, so, previous. Okay. So let me just tease out a little further the three uses. So again, my work and the work of the medical center has been more with the program planning and management. And at a big picture level, risk is most useful. At the end of the day, we want to be able to match patients with the appropriate services and making sure that our medical center has the right services to match whatever the needs of populations is. And risk stratification is crucial for helping us identify that. So trying to plan how many, let's say, care coordination nurses we need, or how many primary care physicians we need to make sure that we're covering immunizations, that sort of work. Other uses this comes up is what is a fair amount of patients for a primary care provider to take? We talk a lot about panel counts. So what is a fair number? And risk stratification really helps us become more specific about trying to answer that, make sure that we're fair for everybody. So the other two uses for risk is, again, a little less at the medical center, but just want to mention it. So there's provider reimbursement. As pay for performance becomes more important, the message I get from providers is they want to be treated fairly. Risk stratification is probably one of the best ways to do that. That's something we really have to improve, because all populations are the same in terms of risk. And is it fair to hold one physician, everything else being equal, to the same standards if one population has more risk than another. And then finally, just the other use for risk would be actuarial underwriting. This is health plan. This is just more on the finance side mentioning. So how do you translate risk into actual concrete, if you're not a health plan and again trying to do classic underwriting for health insurance purposes, how do you translate a risk score into actual planning a population health strategy? So I come from a very strong public health background, and I always go back to just the 3 levels of prevention. I think what's most important about population health is prevention. So I think one suggestion is that you pair the risk groups with the 3 tiers of prevention. So if the majority of your population is low risk, so just going on the age and gender model, so if you have a relatively young population, it's more about just basic immunizations and maybe some health education about accidents or that sort of thing. So what's most relevant for that population? Now, as let's say your population is a little bit older, they start hitting the age for cancer screening. So your risk analysis might inform you that you might need to hire on more gastroenterologists to do more colonoscopies. Again, really making sure that you have enough for good secondary prevention, looking at your whole population. And then finally, based on risk scores, if it's at the highest end of the risk, this is what gets into more care coordination. So for tertiary prevention, if they have the condition, then we want to be able to enable our system to prevent that condition from getting worse. So there, it's about care coordination nurses, case management, that sort of thing. And again, a risk score can help you preemptively sort of plan and get a sense of your population so you can make better decisions, especially when it comes to resource, putting the right types of staff to take care of your population. So any conversation about risk and risk stratification, you can't do this without data. I'm just going to go through briefly some of the what's out there. We're fortunate at the medical center that we do have choices. I hope everybody on the phone has their choices too, and in terms of what data you have access to, but I just want to highlight the pluses and minuses of both quickly. So first of all, there's medical claims. The advantage is that basically there is a bill and there is a diagnosis and there's a procedure, so you know something about the patient. There's some strong safety informatics are built in to ensure some integrity. Again, make sure a claim can drop only when certain conditions are met, so it's structured. The downside to it is there's coding biases. So an ICD-10 code really doesn't tell you a whole lot if you want to get more nuanced about a patient or a population. So somebody has diabetes, it's hard to move further or say more about the patient. And then also, depending on your situation, it's often dependent on health
plans. That will be the facilities, not me.
So the next option that we have is just electronic health records. So this includes like actual laboratory values, statistics, blood pressure, height and weight, and that sort of thing. The advantages is that it's more granular than claims. The downside is that it's not always structured. So especially when you're getting to risk behaviors, smoking, but depending on how your AHR is set up, it might be all free text, which any analyst will tell you is very difficult to do risk stratification from free text. So the best option, I would say, is a hybrid of both. You want to be able to have claims and be able to combine it with your EHR data. So for example, back to diabetes, if you know that your population has diabetes and you happen to have their A1C score, that's going to tell you a lot more than just having the claim alone saying diabetes for the diagnosis. The downside of it is, and again, depending on your organization, you just need to have really strong informatics because sometimes matching patients across systems, especially claims, can be challenging. For example, at the San Mateo Medical Center, each of our service lines, there's a different EHR, so sometimes it can be a little tricky. That's it. But it's definitely worth the effort because combining the claims with lab data or EHR data will really give you a more granular score to help you get a better sense of your population. And then finally, I'll mention patient surveys. Again, I think these are the most challenging to do, especially if you have a population of the thousands. It does, probably you can get a better sense of risk factors in terms of health behaviors, diet and exercise and other lifestyle things. But they're very expensive, time consuming, and, especially if you have a large population, the scientists, it's really hard to do the science well. Building a sample, getting the right patients in so it represents your population, but that's certainly another option. And there are methods and models to try and estimate risk from that. It's certainly possible. Okay. Okay, so let me just describe briefly. So we're still sort of at the beginning level of using risk models and stratification in the medical center, and that's sort of one of my goals for the departments to build this out. But to date, we've done 3 methods. And again, because we have choices, so we've gone from the very simple to very sophisticated. So I'll just go briefly through each. Next slide. Okay. So, so the first one is, so for those outside of California, just briefly, the whole person care, it's basically a program through Medi-Cal where public safety healthcare systems in California can design basic care coordination program for its most complex clients. And when this started out, it was a lot of back and forth between how to identify a population that would most qualify. So we went from a list of all chronic diseases to having care managers sending lists of patients that they thought were the highest utilizers. And then finally, we settled on 4 more 80 visits. So this is an example of one of the most, a very simple way to identify risk. And so far, the feedback that I've gotten from the whole person care team is that it seems to be pretty good. It doesn't necessarily predict something, and if a client falls out, it's hard to capture, but it does seem to make sense. And they do believe that the majority of patients with 4 more 80 visits to date seem to be good candidates for the whole person care program and best candidates for care coordination. So the more medium in terms of difficulty, and it's one that I like, it's called the Charlson Comorbidity Index. And just some of the pluses is that it's been around, it's in the public domain. I like it because it's really about preventing 1-year life expectancy. And I think that's a little more patient-centered than financial risk. Because, again, going back to the prevention model, if the goal is to prevent premature mortality, I just like this, and patients are at higher risk or lower risk, then, I think that's really, really focused, and I think it's very easy to explain to providers. But I would say the downside of it is it's just ICD-10 code dependent. Again, there's coding bias. I guess that's an advantage or disadvantage. You can do it yourself, again, depending on what your analyst's resources are. And I guess the other criticism about it is that this first came out in the late 80s. I mean, it's still around and still used, so it's a good model, but everybody knows with the opioid and mental health issues impacting life expectancy in the U.S. recently, it's probably time for research to incorporate those conditions. But anyway, I think it's a pretty solid, and again, considering the cost, it's a good way to start. So I won't read the list off, it's in the slide deck, but these are the conditions and the Charlson comorbidity. Basically, any patient, you just sum these up and you assign a weight to that patient. And as you see, a lot of these conditions are candidates for chronic care. So those that would score the highest would put them in the highest risk category, so candidates for tertiary prevention. And then anybody below that, you would be able to plan accordingly. We go to the next slide. So just to show you kind of what we learned is that you'll see variation across our primary care clinics in terms of risk. So again, the next step would be to drill down each of those clinic populations, decide what are the top conditions that are driving those risk scores, and then what can we do to help prevent, then we can look at outcomes and that sort of thing, and how can we prevent those conditions from getting worse. And a little bit of a validation. Oh, just one more thing. So if you notice that the senior care clinic population has the highest risk, so there is some truth. We don't know that disease gets worse over age, so more validation is needed, but it's pretty encouraging. Again, I think this is a good model for being in public domain. Okay, the last method I'll just go through briefly is more of a hybrid. This is an experimental. So we're also work with Cerner, and they were developing a sort of a risk model, and they were using our data. And this is, again, an example of a good hybrid model, and they even added a couple of things to geocode our patients' census tracts. A census tract that has social and economic variables, such as poverty, educational attainment, crowding, and that sort of thing. So that was sort of a kind of a plus, which was nice. And this was more of a financial risk model. If we go to the next slide. So just some of the outcomes of that. Is that overall it was pretty good about preventing hospital charges. What we're seeing in terms of assigning patients, when they tested the model after predicting it, it was pretty good, pretty consistent with what we're seeing with other commercial risk models. One thing I want to point out about the downside of risk is that the larger your population, the more accurate your risk score is going to be. The more segmented it gets. Again, it's really hard right now to predict accurately that this person, individual patient, absolutely will be in this risk group. But at a broader level, it's a very useful tool to measure across populations. And we're sort of seeing that with the charge data here. They're pretty accurate predicting actual charges. But when you try to get a little more nuance breaking into the groups, you know, it's always a work in progress. But anyway, it's a really good start. One more.
Will anybody who has their microphone on please mute it, unless you're the speaker? Thank you.
So the last couple points, you know, when any risk, trying to build risk stratification, you need to have very clear objectives. Is it financial risk? Is it event risk? What is it that you're hoping to achieve? Is it planning? Is it something else? Or is it cost containment, whatever? You know, data access and data quality are very important. I think having clear objectives really helps out your access and those data priorities like I talked about earlier. Obviously, provider and executive acceptance and participation is crucial. It's always validation, so we want the providers to make sure that sort of ground truthing what's coming out of the analytics shop. And plan, do, study, adjust cycle. So with Cerner Math, we went through a lot of time just refining our definitions for assignments and clinic definitions and so forth. So it's always an iterative process, and as artificial intelligence and other techniques get better, you know, hopefully our accuracy and ability to predict and measure risk will improve too. So I want to thank everybody for listening, and so I'll be open for questions.
Okay. Thank you very much, Brad. And at this point, let's turn to Danielle Oryn, Dr. Danielle Oryn from Redwood Community Health Coalition. Danielle?
Yeah. Hi. Thank you, and thanks for having me. I'm going to present a little bit different of a perspective from the perspective of the singular health center. So while I do work at Redwood Community Health Coalition, I'm going to speak today on behalf of Petaluma Health Center. Thank you. I'm moving the thing. So our kind of journey around this started from a little bit of a different place, in that I think we're still having the problem with people not being on mute. But one of the problems that we were trying to solve was we weren't necessarily trying to predict at the health center who's going to become high cost or something like that, but rather stratify our population into groups by what services those groups should have. Because up until then, our real methodology for assigning patients, say, to case management or to shared medical visits or to behavioral health was just really on provider referral. And as you might imagine, that's just totally variable. There are people that use one particular service all the time. There are people that use all the services all the time, and people that use them none of the time. And those people could have exactly equal patient panels. And so we thought the other piece of it for us is at the health center level, where we really wanted to be able to look at stratifying our population and kind of defining and looking at our panels, was it is really important to us to be able to compare one panel to another of patients. So be that either by provider or by care team, so that we can staff appropriately, so that we can make panel adjustments if we need to, or make productivity adjustments, or you know, change the expectations as needed to kind of solve for those problems. So we kind of started from this. We want to make sure that the people who are getting case management are people who are high risk, and that we're doing interventions at those intermediate risk categories, and that we're driving our healthy patients to our services that we think are going to keep them healthy, and or prevention stuff. So I'm not sure if I can click the next. Thank you. So one of the big challenges we had in this was that there's lots of models to, you know, out there. We've heard about a couple. But most of those models, almost all of them, require that you have claims data, and we don't have claims data. We have a limited hospital data set. So, you know, we said there has to be something that we can do with the information that we have in our EHR, because we have a real rich set of information with diagnoses, both on the medical and the behavioral health, and we have lots of social determinants of health. We can say something about people's functional limitations, and our data is really real time as compared to claims. So we felt like there has to be something that we can do with the information that we have. And also, doing nothing didn't seem like a really good option for us. So we, you know, thought even if we have to kind of start from a place of not having a researched and evidence-based model, that we would at least put something into place that we could use until we found one that worked. So what we decided to do was to align with this AAFP rubric, which is it's widely available, and published by them. But basically, they're not telling you exactly what to do, but they're saying here's how you might, you know, risk stratify your patients. So look at their clinical diagnoses, look at their potential physical limitations, look at their social determinants, look at their utilization, which some pieces we have, some we don't. And then also don't forget about clinician input. So, and then we would want to line up to kind of a 6 level point kind of value, and then we would kind of drive our services based on where people landed. So if they land in the primary prevention areas, then we are doing regular automated recalls, that we're not spending a lot of other energy on that. And that if they are in the secondary prevention, we're really trying to drive those people to shared medical visits and behavioral health and those kinds of services. And then once they get up into the red, then we're talking about patient navigation and care management and more intensive behavioral health interventions. So we can go to the next slide. So I'm going to actually, one piece that we really thought was important, and I think we have some learnings about this, is that we would include social and behavioral health into our model. We can go to the next slide. So this is what we decided to build in our homegrown model here. So we thought we would incorporate risks, chronic conditions, social determinants of health, medications, ED utilization, and admission. So we know at Petaluma Health Center, we do have a limited data set from our local hospital system where most of our patients get admitted, and that it's just a utilization set of data. So we thought we might incorporate that here as well. So we said if they have a risk, high BMI, smoking, prediabetes, high triglycerides, arthritis, they have chronic pain but they're not on opiates or hypertension, then we would give them a 0.5 point for that, a point for the chronic conditions that you see here. We added some social determinants of health where we had reliable data. So we know about homeless, we know about people who have no insurance, we know who's disabled. We added some other pieces around medications. So both, are they on more than 9 medications? We also added, do they have more than 9 chronic conditions? Are they on a dangerous medication like anticoagulation or benzos or opiates? And then we decided to look at a few chronic conditions separately because of the purpose. What we're really trying to do is, again, to get the right people into case management. Now, for us, our population of patients that are end-stage renal disease, HIV, or they have a cancer, most of those patients are already case managed by the treaters of those conditions, which are outside of our health center. So we wanted to flag those, but we didn't want to really call that out in our risk model, but rather flag those patients to say, are they tucked in or are they not tucked in? And then we could bring them into care that way. So we can move to the next slide. So we built, we took that point value system. We've had to, what I showed you was actually what we came to after a few times running it for our population of active patients and showing it to our provider group. They were able to look at their own panel and say, yeah, that is correct for my patients. I know every single person who's a 6, and that makes good sense. We also went through it with our case managers, and then we decided, well, it seems like it's really reflecting the experience of our users, and since we don't have another way to study it, we're going to go ahead and use it for now and see how it goes. So we built it into our analytics tool. Ideally, you would have it as part of your EHR, but we don't have a way to place that information into our EHR in an easy way, in an automated way. So what we did was we built it into our analytics tool. So now pretty much every screen, every time a patient's name appears in our analytics system, which are all of our EHR users are in the analytics system every day, their risk score appears as well. So we can go to the next slide. So what are we doing with it now that we did it? So we created lists of patients for particular interventions, specifically the ones that that were really caused us to kind of embark on this journey in the first place. Number one, for case management, now we are able to, they have kind of a huddle sheet in the morning that gives the patient navigator a list of everyone coming in on the team that they're assigned to by time, that has a risk score of 5 or greater, that is not already engaged with them. So that instead of relying on the care team to say, oh, maybe this person should have case management, the case managers are coming to huddle and saying, do you have anyone you would like to refer? Okay, well, here's the list that I have of your patients who are coming today who I think I should see. And that has really helped kind of correct the population that they are seeing. So it's been a success from that end, and that led us to, we could do the same thing for behavioral health, so we do that as well, and also for team nurse visits, and it has allowed us also to point particular people to particular group visits. We also sometimes, for certain kinds of visits, we actually want a lower risk score. So what we were noticing was, many of you are familiar with Kaiser's Preventing Heart Attacks and Strokes Every Day program, the PHASE program, is that a lot of the patients that are coming into the PHASE program and were coming in for nurse visits were just so complex that it was really quite overwhelming to the nurses. And so what we did was we said, actually, let's invite only those with a risk score less than 5 in with the nurses, and that way they could actually be really effective at doing that phase medication management, and we pushed the higher risk patients to the case management group. So we also we don't adjust the panel per se of providers by the risk score, but we do adjust the productivity expectation. And we've looked at things like if a particular team has a significantly higher burden of complex patients, do we need to staff differently with nurses? We haven't taken action yet, but we continue to talk about it. So we can go to the next slide. This is just what that list looks like, as you can see, for patients, high-risk patients with an appointment today by team. And so each team's navigator just goes ahead and starts talking to the provider about those patients in the morning at huddle. We can go to the next slide. Again, we have the risk score showing in every area of our analytics. So this is showing our care gaps. This is the list that's reviewed every morning at huddle. We review all of our care gaps. And as you can see, the risk score is there, and we have care gaps now based on the risk score. So we say if the risk is over 3, they should have a screening for social determinants of health done. And so that care gap is based on the risk score. It's also been really helpful to be able to show our providers a breakdown of their panel, both by risk score. So we're able to say how many are high, how many are medium, how many are low, how many are at each number, and how many have each of these chronic conditions or risks. And I think people have really appreciated, the providers have really appreciated kind of being able to take ownership of their panel in a different kind of way when they can easily see the breakdown of who belongs to it. Great. So what's next for us? Oddly enough, we're also looking at the Mary Charlson Comorbidity Index. We've been working with our analytics vendor and Mary Charlson to get that built into our analytics. We're going to take, I think Petaluma Health Center will be the first one to do that. We're going to take a look at how it compares to what we're currently using, because we feel like what we're currently using is functional. We like that there's research behind it, as opposed to our, it actually predicts, it predicts outcome, as opposed to, ours, which predicts nothing. So that's a plus. I think the downside for us in terms of looking at that as a possibility, and I think she's actually got we're looking at a second version, like a 2.0 version of the comorbidity index that does include behavioral health, but it does not include social determinants of health. And so for us, thinking about that, having spoken to her, she said that she feels it should be looked at separately. So we're going to make an attempt to kind of separate those two things out and see what that gets us as compared to our homegrown model. Thank you.
Thank you very much, Danielle, and thank everybody that was on the faculty today. One question just came up specifically for you, Danielle. Hillary Gillette Walsh asked the question, how are you defining homelessness? Do you just use zip codes, or do you have another flag created?
Oh, no, we actually capture that data. FQHCs are mandated to capture homeless data and report on it, and have been for many years. So since our implementation of EHR, we've been capturing that as structured data as patients engage with us, and we update that on an annual basis. So it's not exact, if someone became homeless yesterday and they didn't happen to report it to anyone, we might not know it. We are using the prepare tool, but we only have, I think, like 5,500 of them done out of our 35,000 patients. So I can't reliably use that as that's the only thing, but I will say that using those has definitely, when we get a positive for being homeless on that, and it doesn't match with what the patient has in their record, we are able to update it in a little bit more of a timely manner. But I think we're close on it. Close enough.
Thank you. Thank you. Earlier, Rosie Chang-Weir asked the question, what was involved in the calculation of risk, and are there any social determinants of health included in the definition? Don't know if going beyond what Danielle has talked about, if we want to look at it from LADHS or San Mateo's point of view as well.
I'm sorry, could you repeat? Oh, go ahead.
I was going to say, for social determinants of health, what Cerner Math did, one way you can get to it is based on zip code, or sorry, residence. And if you have somebody that's able to link to census tract data, if you look at whatever the service area of your clinic, you'll notice that there's probably some census tracts that have higher, higher poverty, lower educational attainment, more crowding, that sort of thing. So that's sort of one way to get at it. And what Cerner tried to do was map, at least for San Mateo County, our patients to some of those census tracts. Just factor that in, and there's a lot of research out there that says if you do live in a high, census tract with higher poverty and other measures, that life expectancy is lower. So it's not perfect, but it is sort of a proxy if you didn't have anything else.
Yep. Anything from LA? Deborah, Marianne?
So for within our algorithms, we don't specifically identify social determinants of health. We do look at food insecurity, housing, mental illness, but there is a very large committee at the DHS level who is specifically tasked with looking at social determinants of health and incorporating that within our intake forms and within our EDs, our inpatients. So But within our own algorithms, we don't just identify those areas, but we do work closely with patients who are at risk for many of those factors that social determinants of health actually addresses.
Great, thank you. Question came in, is everybody that's participating in this call able to get access to a copy of this presentation? The answer to that is yes. The recording will be made available through CCI's website, specifically raven.careinnovations.org, and a copy of the slide deck will also be similarly available. There will also be an emailing to people who have registered for this event that will include a link to the video as well as a copy of the slide deck, assuming that your servers will let you get one of 32 meg or better size. Other questions for the faculty? They've been outstanding today. I really do appreciate their support of CCI and its efforts, and wondered if there are any questions. We have about 6 minutes left. Please feel free to unmute yourself now to ask the question or send it through the chat. Great job, faculty. You were truly outstanding today. I really appreciate the view from the large urban area, Los Angeles, and what you're undertaking in LADHS. The semi-suburban area in San Mateo is also contributing greatly to this space. And Danielle, super outstanding from a freestanding FQ point of view. Really appreciate your support of CCI, its efforts with the safety net, and your support of Raven in particular. So if there are no further questions, I hope everybody has a very, very wonderful weekend and look forward to the next session.
Thank you, Ray.